Hope everybody enjoyed their lunch and a walk in the grounds and the lovely weather. How is everyone doing temperature-wise? Are people cold, hot? Are they great? People falling asleep? Graveyard shift, amazing. So this is a session predominantly for this room, basically. So everyone's having breakout sessions. We do have a few people dialed in into the Zoom call, so we're still running the Zoom. But we will start with UCL, and first up are Rachel and James. Rachel, do you want to come up? Well, you both can come up and talk to us about your experience.
Thank you.
Oh, thank you.
Okay, thanks. Just gonna start. Okay, thank you. I'd just like to start off by thanking you for organising this meeting. It's really been great to meet people that I've emailed hundreds of times and I've seen on the screen, and it's great to meet you all in person. So to introduce myself, I'm Rachel Williams, and I'm one of the managers of the genomics facility at UCL. And I'm going to give a short talk really about sort of like setting up COVID sequencing at UCL. And going back to March 2020, it's how we went from the picture on the left to the picture on the right in the space of a few weeks. And this is particularly impressive because you have the backdrop of being in a pandemic, sort of like having lockdowns occurring. And also at the time, we had very, very little experience in nanopore sequencing. So to start off with, the main ingredient for us at UCL was the team and the massive team effort that everybody put in. And this went sort of like it was sort of like facility staff that were willing to come in. We also sort of like the three people at the sort of like far right hand side were volunteers who were willing to come in. We had people on research grants that came in. Myself and Mark Christiansen, the other facility manager, sort of like took care of the day-to-day running, the logistics and everything. And this obviously was all led by Judy Brewer, who is the sort of like one of the academic leads of the genomics facility. So March 2020, we really had to start from the beginning. We were really fortunate. In the top left-hand corner is Paula Rosende Silva, and she was a visiting researcher from Brazil who had sort of like joined the group to set up sort of like sequencing of other viruses using nanopore. And so she immediately set about sort of like changing it to the Arctic protocol, and we had to sort of like set up the labs, we had to set up the protocol. Paula actually designed other primers, so we were testing these primers out as well. And as I say, one of the main things is everybody needed to be trained. There was one person who really knew the protocol. And we managed to get our first training run on the 23rd of March. At the same time, Shenando, who's in the audience, so like parts of some of the group are in the here today, was setting up all the analysis pipelines, which I'm sure he could talk for sort of like an hour on all these sort of like issues and troubles, sort of like setting this up with data storage, data transfer. At the same time as well, Tony Brooks is in the top right-hand corner, was setting up automated systems. We wanted to try and make it as high throughput as possible. So as Charlotte has said, it really was all hands on deck. So like everybody sort of like played their part. In the background, myself and Mark, we were getting all the costings, the processing spreadsheets, the SOPs written, couriers arranged with sort of like COG-UK team, so that we could receive the first patient samples around about the beginning of April. And then by the end of April, not even the end of April, we sort of like had our first upload to Climb, which is a really impressive 300 to 400 samples. So it was great. We were all set up, ready to go. The team was in place. We could process batches of 192 samples, and then we stopped receiving samples. So at UCL, everything sort of stopped by the end of May. So like we stopped receiving anything. So now I'm skipping to sort of what I think is the second phase, and this is sort of like from October 2020 over the winter months. By this time, we had our core COVID sequencing team, which is myself, Charlotte, who is here, so like who is the lead, the COVID sequencing lead, lab lead, Shenando, who has done all the analysis all the way through, and also sort of like we were joined by Marius, who's on the left, and Nadua on the right. Two research assistants who have done just such a fantastic job. They've taken everything that we could throw at them and been so quick to learn and pick everything up. We also have a great backup team of Rose, Helena, Pat, and Alfonso, and their help was essential, sort of like both lab work, analysis, and also admin, which the amount of admin was amazing, because sort of like over the winter 2020, just the sample numbers, it was so busy. So like my recollection of it is it was hectic, it was busy, maybe chaotic sometimes, but so like it was really full on. So we were receiving many more samples than we can sequence. On top of that, we had started doing extractions. So the majority of the samples we received needs to be extracted. On top of that, we were the sequencing center for 3 Hokie sites, which was just another layer of complexity on top of everything, requiring a 48-hour turnaround time as well from when we received the samples. On top of that, and it's a big on top of that, we sort of made the decision, just as Hokie was starting, to change over to Illumina sequencing. We could see samples, the sample numbers were increasing massively, and we just felt that our capacity would be greater if we moved over to Illumina. So Helena, the second picture down, took this task on, and it was amazing. Within a matter of weeks, we had tested the protocol, we had an automated protocol, and we had everybody trained up. So by Christmas, which was actually cancelled as well for a few of us, we had fully implemented the Illumina protocol, and since then we've just used Illumina. So as I say, I sometimes see it as quite chaotic, but Nadua has summed it up really well. We were sort of like, we did rapid sequencing, we were efficient, we were organised, and it was very high throughput. And I think sort of like we have become a really well-oiled team. So this is my final slide, and it's like, so what have we achieved? And I think it's a lot, it's so much that we've achieved. We've uploaded sort of like over 15,000 samples to Klein, and this doesn't include any of the samples for protocol development, optimizations, some repeats we may have had to do, so it doesn't include any of those. We've extracted over 7,500 samples. We were the Hokie sequencing site for 3 NHS trusts. We've sequenced samples received directly from more than 25 hospitals, mainly from the London area, but also sort of like from Birmingham. We have sequenced pillar 2 samples, and then sort of like samples we've received from the PHE. We were involved in the comparison of different sequencing approaches for wastewater samples. So Charlotte, who's in the audience, took that on, and that was using bait capture. We've been involved in research studies. We have taken some like outbreak samples, including prison outbreak samples. And very recently, we've started sequencing sort of like samples from returning travellers. So to sum it all up, really, sort of like as Shenando sort of like put it so well, it's been a really challenging time, and yet most probably the most rewarding time that sort of like we've had. So I'm just going to finish with a short video that Shenando has produced showing the team at work.
Right, thank you. So after that rather impressive presentation from Rachel, I'm going to speak to you about the COG-UK Hokie Trial, which I think, Sharon, you spoke about briefly in your presentation to begin with. This is a bit of a departure from most of the work of the bioinformatics sequencing that you will be doing, but a lot of participating site support for Hokie are present in the room today. So hopefully this won't be completely new to all of you, and for those of you it is new to, I'll try and explain in the course of, I think, 7.5 minutes what I have to, what we've been doing in the course of this piece of research. This is Judy Brewer's pet idea. Judy unfortunately couldn't be here today, so you're getting myself instead. I'm the project manager based at UCL for the Hokie Trial. So what's this Hokie? Hokie is hospital onset COVID-19 infection cases. And Judy's thought was, can we use rapid or indeed not so rapid sequencing of people in hospital with COVID-19, sequencing of the SARS-CoV-2 virus to somehow determine whether infection control practices can be adjusted, heightened, moved around to essentially prevent nosocomial transmission of disease within hospital transmission. So what we were looking at was as you can see the population there, anybody who had a first SARS-CoV-2 positive diagnostic test, 48 hours or more from the point of admission, where COVID-19 was not suspected at the point of admission. So we were aiming to do effectively unbiased sequencing throughout the institution. The trial design, I think Sharon mentioned this, it's a massive mouthful. It's a phase 3, what we kind of thought at the time would be a definitive clinical trial to understand whether this is something which could be taken forward in NHS settings. As it turns out, won't be the definitive trial. I'll maybe come back to that in a moment. We were looking from our statisticians to get about 2,000 or so patients coming into trial, 2,400. We actually got 2,170. That wasn't a target as such. Obviously, in contrast to most clinical trials, we aren't aiming to get as many people with COVID as we can, indeed as few as we can. But obviously, that was the amount of patients that we had with the 14 centres that were participating. I'll come on to those in a moment. So this is an interventional trial, and you might think, well, how can you intervene once people have SARS-CoV-2? They have it. You can't make them better from that in terms of an interventional aspect. The intervention, actually, you can see here is this piece of paper, the sheet of A4 on the right-hand side of the screen, and essentially it's a comparison between patients' IDs in hospital who came into hospital with COVID and those who are suspected to be hospital-acquired cases, or what's called Hokies. And there's a little bit of information there from our statistician as to how the actual model itself works. You can see we use a combination of admission to symptom onset interval and the differences between the observed proportion of flow sequence matches, so a max of 2 SNPs for viral samples obtained from different locations, the same ward, the same hospital, within the community around where the hospital is based, to estimate the probability. And you can see there, for example, you have very highly probable cases on within ward transmission and low probability of within hospital transmission. And one of the main challenges associated with this was that we needed 90% or higher whole genome sequence coverage for the what we call the SRT software to run to generate one of these reports. As it turned out, we found that was the case in, I think I would say not a majority of cases, but a large minority of cases, we didn't achieve that 90% threshold. The other aspects of this, the intention was that this algorithm would actually run quite quickly, quite smoothly, without the need for too much kind of local adjustments. I think if we have a couple of bioinformaticians in the room who were running this project, that was not the case. It needed a lot of work, a lot of support, particularly around the metadata, which I'll speak about in a moment. But it was more of a headache than we anticipated. So in the metadata, which I just alluded to, I think everybody found the metadata for COG-UK itself to be a challenge to collect. You're looking at somewhere between, I think, about kind of 5 data points going up to a maximum theoretically of about 40 data points could have been entered into COG-UK. we were asking for some slightly different things as well as what went into COG per se to run this sequence reporting tool. The NHS teams who were collecting this, I think that they'd been pushed to the points of almost breaking by kind of, doing COG itself at the height of the pandemic, particularly around kind of, January, February 2021. I think adding this into the equation made it even more challenging for them. And I think were we to go and do a successor trial or to run this as kind of, NHS standard care in the future, this is one of the main learning points I think that we would say. You can't be collecting this by human action. It has to be automated, probably through the kind of EPIC system, Cerner systems, pulling it through the back end. And we're doing some research at the moment as a successor part of Hokie to determine how easy this is to actually do. So in terms of what the clinical trial was, you can see the flow of kind of clinical activity there in the main part of the screen, and then over to the side, the completion of what we call case report forms, these clinical trial reporting mechanisms. So you already have quite a lot of work going on. You have writing of or reviewing reports, actioning them. You have filling out the trial paperwork, and I think one of the things which I would reflect on now is that if we were going to do this again, we will be doing this in a very minimal, modest data set in terms of the clinical trial data collection. Unfortunately, because we designed the case report forms last summer, where there was very little COVID activity in the UK, we went pretty much the other way on that and collected between 250 and 400 data points per patient for the 2,000 patients identified. So you can kind of see what the piece of paper is you'll be completing here. There's in the region of, what do we have, 1, 2, 3, 4, 5, 6 forms of about 6 to 8 pages long per form. And then all of these data points, they come from a very diverse range of sources. You might be going to your wards, go and get some of the data. You might be going to your EHRs for some of the data. You might be going to your LIMS system for some of it. You'll be going to your university lab in some cases. It's a really kind of diverse range of places where the data had to come from. I think, again, were we to do this in the future, small range of data sources and small volume of data coming in. So the wonderful sites who agreed to participate in this listed here. So we had 14 in total covering Scotland and England. We did try to get Wales and Northern Ireland on board, but I think for logistical reasons that wasn't possible in the end in Q4 of last year when we were setting this up. But still a really nice range of everything through DGH hospitals through to kind of centers of excellence in sequencing. The thing we found was that the workload wasn't spread evenly over either time or by sites. You can see I've anonymized the sites here, but you have between, say, 40 on the low end for site 13 hospital onset COVID cases, going up to an order of magnitude higher for site 8, for example, 450. And obviously there are differences in sizes of the trust participating. Some were a single hospital, some were anything up to 10 centres within one trust. But you can see again the proportion of where the hospital onset COVID cases were coming, 1, 21, fairly evenly high across here. So in terms of the sites having to allocate their resource, their research nurses, bioinformatics team, sequencing load, very challenging, I think, for the sites to, nobody knew ahead of time, of course, of what was going to happen. And I think by October, there was a sense of potentially very little might happen at all. By a month or so later, all hell was starting to break loose. So in terms of kind of clinical trial planning, the allocation of resource, very challenging. I think, Sharon, you did say to us, going back into last summer, shall we just have kind of 4 or 5 sites, keep it easy for yourselves? So we said, no. We're going to have it larger. We're going to make sure we catch everything. And that is, of course, what happened. So this shows all the different sites participating, what phases of the trial, the baseline data collection, slow phase, rapid phase, where they were doing it chronologically, but then also looking at where the peaks were of hospitalizations in the UK per day on the kind of purple overlay. And you can see we almost kind of missed the peak of the epidemic wave 2 in Jan, but then again, for certain sites have started to come into the rapid phase. For a lot of the work, we actually missed most of the intense period completely. So again, for us, very challenging to try to work out when to start it so that you actually catch the key data collection points, but you're not also overwhelmed by the crest of the wave. So I think I'll just quickly summarize, and we're taking up too much time. In terms of the sequencing, as I said, between some of the sites, they missed 20% of cases by the lack of 90% coverage of the genome. In some cases, it went up to 75%, and we think that was for reasons relating to essentially the kind of sequencing methodology used at the sites. And we'll have one of our teams doing a separate paper on that to kind of dig into the granularity as to why that happened. The metadata collection covered a total, we think, about 25,000 samples, so that both the hospital onset and non-hospital onset COVID cases. Massive amounts of work to do for the NHS sites. Wouldn't try to do that again in the future. The turnaround time as well, I haven't really alluded to that too much so far. We were looking for 48-hour turnaround from the patient being swabbed, so getting the SRT report into the hands of the infection control team. We achieved that in 4% of cases. So I think, again, were we to do this in the future, and the aim is to do a success trial, I think we'll be a little bit more realistic about the kind of timeframes that are reasonable for what we might call a kind of rapid, high-speed turnaround. And again, as I mentioned, the CRF forms for the clinical trial purposes, extremely challenging. The NHS staff were already overloaded, uneven workload between the months, and also the content extremely detailed. It seems the IPC consultants and what the research nurses could do really quite different. But then, yeah, that's where we are. So in total, we had about 150 staff. That might actually be conservative. I think it's more like about 200 staff involved in the Hokie trial. Those are some of the key folks they're listed on the screen. The overwhelming majority of people I couldn't list out, but they're listed within NHS trial sites here. Wonderful team effort from everyone involved. And I think I'd just like to say thank you to everyone in the room who helps us with this, and we look forward to having the results of Hokie out probably just after Christmas with a bit of luck. So we'll keep an eye out for that. Thank you.
I think because we have quite a packed afternoon, we'll probably just move straight ahead. But I think James and Rachel will both be around during the coffee break and after. So if you have any questions, give them a shout. So our next speaker, who's already joined me up here, is Dr. Andrew Page from the Quadram Institute. And I've also listed Nabil, and you'll see why in a bit. Please welcome Andrew.
Thanks. So I'm Andrew from the Quadram Institute, and not here is Justin, who's the Irish guy with the facial hair. He's moved to Nanopore, but he'll be here later. So I'm going to talk to you about some case studies we've had and some just kind of interesting uses of data we've had over the past few months in Quadram. And so Quadram covers, or had covered, like Norwich and Norfolk and a bit of Suffolk and Essex. So, kind of the east of East Anglia. All right, and we had a little paper at the very beginning of the pandemic, maybe after the first 6 months. And this is really to illustrate the number of people who are involved just in getting basic things started up, in this alter list. It was a phenomenal effort by a huge number of people just to get very, very basic things set up. And yeah, we started sequencing on the 8th of April with a 50% positivity rate from the local hospital, which is kind of crazy now when you think about it. And we actually made a decision to sequence every sample that the hospitals gave us, regardless of CT and regardless of quotas. We just kind of ignored that. But, our bosses just said, spend the money, which is quite unusual in research. Okay, so the first kind of thing first kind of case study I want to bring up is about some care facilities we looked at. And we were asked to look at a particularly bad outbreak in one care facility, and a lot of people passed away. And randomly, when we started looking at this, we saw actually there's a bit of a heat map here, when we overlay just the outer postcodes on a map of the local area. And we found that actually it wasn't just one care home, it was a couple of care homes in one small area, which is not good. And not only that, they all had kind of the same lineage, and it had the same kind of common mutations, so we knew we were dealing with something that was possibly linked. And then we looked further, we found it was all old people, like very, very elderly people. They shared the same postcodes, and they're all within a small geographical area, like very small. So anyway, we looked deeper into this with some help from Dinesh. I don't know if he's still here. There he is. Who looked into the more detailed data. And yeah, so we found that there was like 89 cases, and most of those we could actually link directly to a few care facilities. So we suspect that it was probably just staff movements between these care facilities, because this particular lineage wasn't in the community. So that, you know, that's kind of alarm bells there. And it wasn't really in the hospitals, although some people had to come from hospital. So it was a problem. And then when we looked at like some of the small towns, you know, we had one case where there's a small town of 5,000 people with 2 care facilities in it. And the circulating lineages were quite different. You know, there's a wide variety of different lineages within the small town, but actually in the care facility there's only one. So they've done a very good job, you know, keeping the stuff in the community out, but they haven't done a good job of keeping the stuff, the inter care home transmission out, unfortunately. But the good news is that the outbreak ended and the lineage became extinct. But it was quite bad. Another big problem with Norfolk is we have a lot of poultry production, a lot of poultry farms and poultry factories, and so a very, very high percentage of the poultry that is consumed in the UK and in England comes from factories that are in Norfolk. And so there, a guy rocks up to the local hospital with COVID. He's quite severely ill, and they then once identified that the person was working in the cutting room in a poultry factory, you know, alarm bells started ringing. And so then we were actually working very closely with the local health protection teams and with Norfolk County Council. So they sent out, the Director of Public Health sent out teams to go and do asymptomatic screening of everyone in the factories. You know, they did hundreds of tests. And then they gave us a few of them. They routed them through pillar 1. And we then were able to sequence them in under 24 hours. You know, we took a random set of 27, and they're all the same, identical. So, which told us that it was a problem and it was an outbreak. And they're all basically identical. And what was even better, well, not better, but what was even more interesting was they all had like 2 particular mutations. So we could tell actually that this was a distinct branch, and that it was quite unique. It hadn't been seen in the UK previously. So there could have been cryptic transmission, of course, but actually the most recent common ancestor was in Portugal. And by complete coincidence, quite a lot of these staff were Portuguese. None of them had any travel history, they said. And but there was significant language issues and difficulties, and people were very, very unwilling to talk to the people who went out to testing. It was only when they gradually got more information when going through other routes. But anyway, this particular lineage then stuck around, right? So that was one factory, and then it spilled over into another unnamed factory. And then it spilled into another. So what we found out then was that, so we're able to track these outbreaks, and then all the samples are being routed through pillar 1 as they're doing asymptomatic screening. And so the problem was that they had agency staff then moving between the factories. And of course, these are very low paid people, you know, absolute minimum wage. A lot of them are not native English people. And so they would obviously take whichever jobs were going and where their agency sent them. And so they were going from factory to factory and then spreading it and, you know, causing more and more outbreaks. And we could track this. And then, of course, there's some spillover into the community and into the local hospital as well, and into other wards and staff members in the hospital. So not good, but actually it was reasonably contained. And then, you know, we kept a good eye on the rest of the data in COG-UK. And I think there's one case was identified in Sheffield, and that's it, you know, outside of Norfolk, or Norfolk and Suffolk, so that's kind of great. So it was kind of contained to the local area. And then there's a 4th outbreak, which is another big one, although they were pork, but we were able to show pretty rapidly that actually was totally unlinked, and it was just coincidence, it was a different lineage altogether. And yeah, this is monitored and spread was more or less stopped by a huge public health effort and a lot of asymptomatic screening. There are a lot of problems with this, like people weren't getting paid when they're sick, and people were reporting for work, and you know, all the usual kind of stuff. So once those policies changed, it actually did help a little bit. And then it spread for 5 months and went extinct. Then obviously we had alpha. Okay, so then the next kind of case study is like on a little hospital outbreak. So so this hospital it's about half an hour from here. And, you know, we're in regular contact with the clinicians up there, you know, giving them an idea of what's kind of circulating around. And we flagged up that there was something unusual going on, this B1177, so the Spanish lineage. And he said, listen, you know, this is very distinct and it's unlike anything that is in the community. It's distinct just to the samples you're collecting in your hospital. And so they went and did a little bit more work, but then by the time they'd done a bit of work, it had spread to 11 wards, which obviously is not good. And when they actually went in, they started dissecting it and looking at the genomic data. They're up to tell actually there are 2 waves. So the yellow one is actually a patient-mediated wave, right? So that's patients being moved between wards. And to handle that, they brought in testing of patients before they would move. They'd make sure they'd be tested and with rapid PCR. And actually they used it as an excuse to get a local rapid PCR facility there. And then the other one, the red one, was staff mediated, and that was just you know, obviously staff going ward to ward. And so we identified like the earliest cases were in staff. And so when they stopped staff moving around, it did help as well. And then of course, alpha, you know, kicked in, and that was the end. All right, so this is actually just what I said. But yeah, it's quite useful doing, you know, basically sequencing every single positive in a hospital, and you can get this information out and you can see it flowing through a hospital, and you can see what's happening. So with the traditional kind of mindset that people had was that 11 wards, you've got 11 outbreaks. What's the problem there? You know, you deal with each one individually, but actually we're able to show that actually they're all linked and they're all identical, and you can actually tell the progression as time went on. So it's a very, very useful tool. Right, so next we're going to go into a video. I have not seen this video, so it'll be interesting.
I'm Nabil Farid Ali Khan, and I am a bioinformatician at the Quadram Institute, and I will be your host during this short video where we will be meeting the people behind the COVID sequencing science here in East Anglia. It's difficult to remember how all of this got started back in early 2020, but to jog our memories, I have included this short clip from the MicroBinfy podcast recorded in June 2020. In the recording, Justin O'Grady and Andrew Page discuss how it all began.
Well, in March, I was on jury service, and an email came in to Justin and I asking, did we want to be part of a consortium to do some sequencing of coronavirus? And I thought, oh yeah, sure, why not? And in literally no time, this entire consortium came together. Normally these things, putting together a consortium would take months and months or even years. And this seemed to be a matter of a week or two. And to be honest, we started doing everything before even paperwork was done or signed, because this is obviously such an important thing to get done. What about you, Justin?
Yeah, well, got the same email as you did, Andrew, and then talked to John, our boss here, and then we decided, could the Institute deliver on such a program? And we decided we should do it, and it would be a good idea to get involved. But like you, I thought it would take time, and I thought this was an initial just tester from them to see would be interested. But what I didn't realize at the time was that a grant had already been written and submitted. And it was only a few days after we received the email that they had been awarded the grant. And then within 2 weeks, we were sequencing genomes.
And for those of you who don't know, the Quadram Institute is based on a campus which also has the regional hospital, NNUH, and it also has the medical school for the local university. In one small little area, you have everyone you need to make a project like this happen.
It was fortuitous in some ways that we had everything. We had the dots already joined for other projects. What we had to do was go through the biorepository, because that allowed us to put in place the ethics that we needed to collect these samples and start working on them almost immediately, long before the official ethics for the study had come through. the COG-UK consortium from Public Health England. So we were able to get up and running very quickly through the virology department giving us the samples and the biorepository handling the samples and handling the metadata and anonymizing the samples for us so that we could proceed with work.
Do you remember what it was like back in April 2020 when we were all trying to just adapt to a new situation and we were all afraid? But there was a sense of optimism that we would overcome this together. Here is a clip from that same podcast episode where Andrew and Justin talk about the new mode of working under pandemic conditions.
From the lab perspective, we had to get people to volunteer to come to work. We put out a call to ask people who would be willing to come and do some work on coronavirus sequencing. And we got a number of people responded to that, a number of people from my group, because they have a lot of expertise in this clinical sequencing area anyway. And so, yeah, we had to put together a bunch of volunteers who would be able to handle each part of the process that was required. So the process would start with sample collection from the clinical virology lab, and then it would move, then the samples would be brought back to the Quadram Institute, and where we would make cDNA and do PCR, and then we would move the samples to sequencing, and we had other people to do that job. And then the data that would then be sent to the bioinformatics team.
There was a lot of people involved. There must have been about 26, I think, at one count. And then everyone needed to have backups just in case to get coronavirus.
We tried to separate teams at one point here. We wanted to have independent teams so that they wouldn't be working at the same time in the lab, shall we say pods, so that they wouldn't give the coronavirus to each other. So if one pod went down, we'd be able to switch to another. But luckily, we didn't have to make use of that because nobody got coronavirus except me.
Working on SARS-CoV-2 in those first few months was unique, I would say, as a gross understatement. While I was getting my head around the frenetic pace of data submission on Metadata Fridays, others were grappling with problems in the lab. I spoke to Alex Trotter, one of the lab scientists here at QIB, about what it was like to work on SARS-CoV-2 at the beginning.
At the beginning, it was a whirlwind working on this, really. It was strange to come into this environment where we'd been working on clinical metagenomics for years, but never with this sort of turnaround time, never this sort of pressure to get samples, get them processed, get them out the door, get the results. It was strange, but it was good. It was good to come in and do something. I don't think any of us could have just sat at home with the experience we had, knowing that we could do something to help in this situation. We all felt we had to get out there and be part of this, really.
The bioinformatics wasn't easy either. I also spoke to Leo de Oliveira Martins about his experience working on SARS-CoV-2 sequencing.
Back in April 2020, in the beginning, working on SARS-CoV-2 sequencing was quite challenging. It was long hours, no weekends, as we are all very familiar with. While I was trying to predict which analysis would be more useful, learning about existing tools and checking what others were doing in order to create the most useful tools as fast as I could.
In retrospect, COVID became everything in life. At home, we had all the fears and uncertainty that everyone else felt when they were watching the news. But we also had to deal with COVID at work in the academic sense, trying to solve problems as scientists. I asked both Alex and Leo about their most challenging aspects of their time within the COG-UK consortium.
The most challenging aspect for me was just the relentlessness of the work that was coming, the pressure to always keep having this top quality work coming out routinely all the time. And it was just difficult to switch off from that, really. You had to be thinking about it. It was on the minds day and night, the weekends, just always thinking about where are the samples, what are the results, can we be doing anything better? Finding the time to do that meant there wasn't really time to do other things sometimes when the peaks are at their worst.
The most challenging aspect of my time within the consortium so far has been the scale of the data sets, since currently the databases are so large that they might exceed our space quotas or they simply do not fit into our hard disk. And so we are having to revamp or to create the tools in order to manage it. Another challenging aspect is to reconcile our time with other responsibilities. Since although this work is expected to become routine, the analyses do not become easier or faster, even with the creation of all the amazing tools by the COG-UK teams, which are transforming these impossible tasks into difficult ones.
I feel that around late 2020, we started to pick up a rhythm. The work was always difficult, but it was becoming procedure. And with the news of vaccines coming around the corner, things were looking up. And then something happened.
Yesterday, the Health Secretary and West Suffolk MP Matt Hancock spoke about a new variant of COVID-19 which could account for the rapid spread of the virus in some parts of England. At the Quadram Institute in Norwich, they've been tracking the new variant, which they say was involved in a surge of COVID cases in Wymondham recently.
We saw it in Wymondham in November, and since then it's risen to about 16% of the cases that we sequence in this particular region. So it's expanding quite rapidly.
This variant would be known as the Kent variant, or the UK variant, or Alpha in the end, changed everything. I think we all knew that there would be a variant evolving at some point, but I think we were all secretly hoping that we would have cases under control and a vaccine distributed when it did. Anyway.
Welcome to Look East. Tonight, the Indian variant of COVID. How worried should we be? As cases in this country double, scientists in this region are leading the fight against it.
Scientists don't like what they don't know much about, and we don't know much about this variant. So we want to proceed with caution because we don't know how this variant is going to respond to our vaccine.
I asked Alex about his thoughts on the emergence of VOCs.
The emergence of Vox made a really big change in how we were working on things, because suddenly everyone was very, very interested in what we were doing, which people necessarily weren't beforehand. We were sometimes just sort of there doing our thing, reporting back, but once the Vox started emerging and people became more conscious of what was going on with SARS-CoV-2 and how COG-UK sequencing efforts would really make a more obvious difference, then suddenly everyone was very interested. Everyone came out of the woodwork. Everyone wanted sequencing results. There was suddenly so much more interest in getting real rapid turnaround time on samples if there was any suspicion of a VOC. We had to sort of change our pipeline, I suppose. We would have our routine work on one side, and then we'd have to have some capacity to be able to really fast track some samples when someone gets in touch with us. It was quite a challenge.
Well, here we are. That brings us to today, and now looking towards the future. For the final segment of this video, I asked Leo and Alex about what will be the legacy of COG-UK.
The legacy of COG-UK for me will be that clinical sequencing of any kind is a diagnostic tool that can be used and will be used going forward. That there is a place for sequencing within the diagnostic pipeline that isn't just in the heads of academics, in papers, and clinicians will really start to see the value of this.
The legacy of COG-UK is the amazing software for classification, analysis, and visualization, as well as the groundbreaking analysis and results that helped us manage. For me, the main legacy will be the collaboration network which was created and the generation of scientists that will be capacitated by it.
Thank you very much, Bill Free, for this amazing video. Thank you, Andrew, and thanks to Justin and Absenti as well. Next up is a presentation from Sanger and Alan. Keith, the floor is yours.
Thank you. Yeah, so I don't think I can really say much other than what everyone else already said. That it's pretty great to be here in person and see you guys in 3D. So yeah, I guess I'll just crack on. So yeah, this talk was initially going to be done by Sonia, but she couldn't be here. So I've produced something and I've actually got a clip of one of her interviews that she gave a couple of months back, just as a very quick introduction. So I haven't told Sonia that it's there, so if she's listening in, sorry, you've got to watch yourself, or not.
Here at Sanger, we received between 400,000 and 500,000 positive and negative samples in a week, and we sequence at the moment around 20,000 samples per week. From the genomic surveillance point of view, as soon as a variant of concern is detected, this information is then provided to the public health agency that use that information to contain the spread of those variants. So the genomic data that is generated through the genomic surveillance operations is immediately shared at the national level and at international level. The sharing of the data in a pandemic is absolutely fundamental on how you control the pandemic, because a variant of concern appearing in one part of the world affects the whole world. The activities of genomic surveillance with COVID have been an incredible learning experience. We are still learning as we go, and we will still be learning even after the pandemic ends, and looking back and learning for all the data that was generated during the pandemic. But I think we have built the resources, we have built the infrastructure, we have built the analytical methods. So we will be better prepared to respond to future pandemics.
So that's, yeah, just as I say, a very quick introduction to the work, as well as what Christina has already presented earlier today. I know that was, I think, maybe 2 months ago, Sonia said that we're at 20,000 a week. That's already 2 months later, now 40, pushing 45, as Christina's mentioned. So again, you've already seen this banner. Christina has spoken about the two numbers on the left. I think probably something I'd like to touch a bit more on are those 300 plus people, staff that have been involved in the work that we've done. Obviously, it would be impossible not to talk about the scale of it, but yeah, we'd like to just bring some of the people behind the project to life. So what happens to samples when they arrive? They're greeted by Team Reefers here. These are two of our, the Team Reefers is a new team. This is two of the members here. And I'm sure most of you have seen many of these photos before, but hopefully they kind of give you a little clip of kind of how massive the scale is. These reefers really do kind of take over. I was working on this project for over a year before I actually got to come on site and kind of get to see the scale of it and get to meet you know, the guys on site and kind of what they'd been dealing with throughout the first kind of year. So where do we get these samples from? Well, nowadays we get all of our samples from Pillar 2, which are the lighthouses placed here on the map. In Cambridge, no longer send us samples, and actually this week Randox there in Northern Ireland no longer send us samples either. We'll see how long that goes on for though. So many of you will know me, and I often complain about, you know, sample quality coming in, and that's kind of, when I'm coming to meetings, that's usually what I talk about. But I think it is sometimes nice to, I have a lot of positive things to say as well. And I think it's quite nice to bring some of that to the front, not always complaining. So we have 3 teams that we're very close with at the lighthouses. We have Glasgow there on the left. Sarah is second from the left there. And then Audley Park, 4 in from the right is Reshma. These are 2 Sanger staff that we've put in the lighthouses to help us at the back end. As Christina mentioned earlier, the lighthouses were initially seeing this as kind of as waste products that they were giving us, and kind of thanks to work that everyone in this room has done. Genomics and variants becoming kind of household words. We've really seen an improvement in the quality of sample coming through to us. Milton Keynes as well, we do have a member of staff there. Kate sadly isn't in that photo, but she did send me a photo of a cherry decoration that her daughter made for the cherry picking room, which has been quite nice. So again, just, oh, doesn't sound good. It sounds looking at. I'm zooming in. Yeah, so while Milton Keynes and Ollie Park went for some boring team names, Team A, Team B, Glasgow named all theirs after lighthouses. So that's the Barrowhead Lighthouse team. Fun fact, it's the tallest lighthouse in the UK. You know, you come here to learn. But we do have to get all these samples to us, and that has been a challenge in itself. The team that we use, our BioCare, they've sent me some mugshots, and in fact, they've sent me this one of these photos from early 2020 when the army was actually involved in packing and the logistics part at the lighthouse end. Maybe it's not something to brag about or boast about, but 2 of our 5 dedicated -20 vans have travelled over 64,000 miles each just in the last 3 months. Yeah, it's probably not something that we want to boast about, but it is just, you know, yet another part of kind of the whole challenge that we're facing. So if we come back to the Sanger team, this is our pre-PCR lab. I went through with Anna last week, taking surprise photos of everybody, which is hence the faces in some of these. Christina mentioned earlier today, but yeah, you can see there are brand new, well, they'd be brand new in any normal case, but the way that COVID moves, they feel quite old. These BioZeros, I think they've been in for 2 months and they already feel that they're part of the furniture. Same again with the Beckman robots over there on the right. They only came in this year, but they already feel that they've been around forever. So this lab deal with essentially plates that come in from the lighthouses. I've said that I sometimes complain about how quality comes in, especially when they were treated kind of as waste. They have improved massively, but just kind of a very quick example of some of the barcodes that we get in. Initially, Milton Keynes were using paper barcodes, which doesn't really work when you're freezing and thawing plates, so they would be constantly ripping and unscannable. Again, we have some plates with 2 barcodes on. We have no idea of what is in these plates, so sadly those have to get binned. Final ones here are either squint or entirely upside down, which I'm not quite sure how that works. But yeah, last year we could deal with some of these a bit more easily because we ran a very manual process. But now obviously everything's entirely automated. So if anything doesn't come in meeting kind of the high standards now, then they just don't get picked. And I would say, although the lab might disagree, that the quality is pretty great now, and that is thanks to, in part, to those teams previously. So yeah, if we go back to Sanger, this is our post-PCR lab. Again, more surprised faces, as well as some more official photo shoot photos, that you can probably tell the difference between them. Probably the most exciting thing on this slide is that central picture, one of our brand new NovaSeqs that was installed. I think this one was installed last week. So we now have 2 in that room, with another 3 getting installed in the next 3 weeks. I think that will take our fleet of dedicated NovaSeqs up to 7. Each of them will have a capacity of around 10,000 samples per week. Obviously, none of this would be possible without all these people in these photos. And just in the lab, I think they've recruited over 60 people this year. I don't envy the guys doing the interviews for those. That is a lot of time given up to that. And I'm just sad that I couldn't capture more people. But yeah, what can you do when you've got over 300 people? I can't get photos of them all. What I can do is put up quite a nice graphic, I think. So this is a graphic of the nationalities of 2 of the teams that we have working on COVID. I think there's around 120 people in this sample size. But yeah, it does give you kind of an idea of the scale and people that we're working with here. And it's just a really nice picture. I'd like to actually build this further, get everybody that has been involved, and when COVID ends, put together kind of a more complete picture of where everybody's been from that's participated in this. Now, I'm not going to talk about the output of the genomics. I'm definitely not the best placed in this room to be talking about the output and the science. But one of the things that obviously has been the output of this, as the power poses and the paparazzi that many of you will have had to have dealt with. Jeff Barrett at the back there at Sanger has done so many interviews, and there was a while where our senior management sent us a weekly update of the new interview that Jeff has done on the BBC or wherever else it may be. So yeah, it's obviously not just been Jeff. I think you can see there, Naomi did one, I was over there, and various other people at Sanger have done plenty of interviews. I know Sonia has in fact done some international interviews in Portuguese for international audiences. So working from home, very glad that we had a stock image from Sanger of a office at home. I didn't have to take a picture of my own room to put up here. But yeah, I think these are both pretty standard photos for most of us now in this room, unless obviously you're lucky enough to be getting out the house and into the lab. Yeah, I have to give a special mention over there. The lady in the left-hand photo is Tanya. I don't think we would have got past a couple of months without Tanya. She's kind of been there from the beginning and really managed to push us through with just sheer force of will. There's a lot of us, we know, over 300 of us, but we do like going our own ways, and we don't like keeping anything very organized. So without Tanya, I do think we would be a bit lost, honestly. Obviously, speaking of Tanya and non-lab staff, we have a huge number of people who are not based in the lab. Here, we know we've got LIMS teams, we've got QC teams, analytics, IT, infrastructure, the whole host of people. I'm never going to be able to go over them all. I do need to ask Rich why he's on his tiptoes there in the top left. I can't work out that, but we'll get to that maybe another day. So yeah, I think this isn't a sample of everybody, but hopefully it does give you a bit of an idea of kind of the people and how people have been working during COVID. A couple of the other kind of non-lab staff that aren't included here are the flavour of the month, which is probably procurement, dealing with numerous shortages. We wouldn't have been able to scale up without these procurement staff putting in those hours. And again, probably another flavour of the month would be the legal and finance teams working on the contract that we currently signed last week, 2 weeks ago, with the Department of Health. Now, obviously, our process has changed and the world has changed massively since 2020, but we wouldn't have got kind of where we are as a process without, you know, many of the people putting in the hours back in April last year and throughout 2020 and early 2021. Again, I wish I could put up more pictures of people, but yeah, they've really laid the groundwork for us, and you know, they're the reason that we can do what we do now. And they didn't have to come in. Everyone here volunteered to come in and work, and yeah, we're massively thankful for the work that these guys put in to lay the groundwork. I think that's that. Again, acknowledgement slides are always difficult when you have so many people, but yeah, this is just a very quick summary of the people that have worked on Project Heron. Thank you.
Thanks, Alan. Great talk. So our next speakers is a group of three to represent some of the work that's carried out at the University of Cambridge. So first off, we're going to start with Estee, who's going to talk about some of the research side of things. So.
Great, thank you very much indeed. I'm not actually meant to be here, so if you can just imagine a tall, skinny, bald-headed Northern Irish bloke called Ian Goodfellow, I'm representing the Cambridge COG-UK team, which was very much headed up by him. So like everybody else, I'm going to start with a how it started slide. So Ian was invited to participate in COG-UK in March 2020, and there were two things really that happened that made us all sort of work together so well. First of all, he used his experience of setting up field sequencing in West Africa for Ebola and Zika to set up a nanopore sequencing pipeline in 2 weeks in his lab in Cambridge. And he basically decided just to sort of buy some hydroponic tents from Amazon and get things up and running. So I think he had his first run within a week and his second run of 300 within 2 weeks. And this enabled us to go from receiving the sample in his lab to generating a sequence within 24 to 48 hours. The other thing he did that was absolutely amazing was that he went out to assemble a team comprising people from the Department of Medicine and the Department of Virology, so PhD students, postdocs, anyone who happened to just be kind of lying around, and persuaded them to come and join his lab team. He also worked very closely with the NHS diagnostic microbiology team, particularly Martin Curran and Surendra Palmer, drawing them in to help retrieve the samples from the diagnostic lab. And then also sort of collared some random clinicians like myself, Will Hamilton and Ben Warren. And we were able to help with sort of extracting the clinical data, metadata in an automated way so that we could do that on a daily basis and give him the metadata that he needed to accompany the samples. In the end, so initially we started off just getting samples from the diagnostic lab, which at the time was run by PHE. But over the course of the first epidemic wave, we also started a healthcare worker screening program and started sequencing those samples. And then Ravi Gupta, who I think is in this room somewhere or was, developed a SAMBA point of care test. And again, we attempted to sequence samples from inpatients. So we had sort of different types of samples coming into the virology lab, and obviously they had to be extracted and go through the sort of standard processes. And we obviously used the Arctic protocol and nanopore sequencing and were able to generate sequence data within 24 to 48 hours. We've, I think, processed over 15,000 samples to date, although it looked like we only had about 12,000 uploaded, so I'm not quite sure what happened to the remaining 3,000. And what we then did was we used to analyze the genome sequence data together with the epidemiological data and present it to the hospital. So this slide basically shows the first epidemic wave curve of the first wave at CUH. And what you can see is that initially we had mainly community-acquired infections, but over time we had more and more hospital-acquired infections, and therefore we decided to see if we could use genomics to help us to investigate outbreaks of infections in the hospital setting. And you can see that we started to also sequence some healthcare worker samples. And what we did was we set up a process whereby the clinical data of the hospital, suspected hospital-acquired cases was collected by an infectious diseases registrar who filled in a standard pro forma. We extracted lab and epi data from the hospital information system called EPIC, and then we combined those to do a combined genomic and epidemiological analysis. And we would basically meet once a week with the hospital team, which involved clinicians, infection control, patient safety, and hospital management, where all the cases of hospital infection would be reviewed and presented, and then we would provide the genomic data. And we would basically use that to try and support their investigations to say, yes, we do think this is hospital-acquired or this isn't. And on the basis of those discussions, the infection control teams would decide what to do with that information. Now, this happened sort of week after week after week in the first wave and in the second wave. And in an ideal world, obviously, one would do those analyses every single day, but the analysis relied on basically one postdoc who worked relentlessly for months to do this. And so we decided that in terms of efficiency, it made sense to feed this back on a weekly basis. But obviously, in an ideal world, you'd be doing this on a daily basis. Okay. And what did we find? Well, when we sort of looked at the genome sequence data, we generated phylogenetic trees, and we found that there were clusters of infection on certain wards. And when we looked into those, we could see that there was evidence of ward-based transmission involving both patients and healthcare workers. We also found an outbreak on our dialysis unit, which was related to shared patient transport and shared patient waiting areas. And we were therefore able to change the way that patients were transported to hospital and how they were segregated prior to dialysis to prevent further spread. And then finally, we also identified a community-based outbreak, which involved some wards in the hospital, a care home, showing that there was sort of movement of infection between hospital and care home settings. So this was all sort of published quite a while ago in a paper that came out in the Lancet Infectious Diseases. And in that paper, we described how we set up this system of real-time genomic surveillance during the first wave of the epidemic at COH. And we sequenced about 1,000 genomes in the first 6 weeks, and that captured about 70% of all the COVID cases tested in the hospital at that time. And we identified a number of transmission networks which involve both patients and staff in hospital and community settings. And what we did, I think that was novel at the time, was we managed to integrate clinical epi and genomic data and present this weekly to an infection control management meeting in order to sort of support their investigations, but also to help them to guide their infection control interventions and feed into sort of patient safety reviews, because obviously there are duties of candor where if a patient's acquired COVID, have to explain it both to the patient and their relatives and try and put in measures to make sure that this doesn't happen in the future. Okay, so I'm now going to move on to the next piece of work. So one of the things that we noticed again was initially a lot of the cases were community acquired, but we seem to notice that there were large numbers of cases coming from care homes. And what you can see is, again, this is the epidemic curve from the first wave, and you can see that at the beginning there weren't many care home cases, and this may be because there was very limited testing in care homes. So over the course of the study, the care home testing policy changed so that by the end, I think in May, there was much more comprehensive testing. But what you can see is that, you know, the curve seems to be skewed a little bit, and a lot more of the cases seem to be coming from care homes as time went on. So Will Hamilton, who was a postdoc, sort of wondered about this at the time and said, you know, shall we have a look at the care home data? And so we decided to do that. And we basically collected clinical data and samples from patients in the east of England between February and May. And I think this was about 7,000 patients, of whom about 1,100 were in care homes. And the samples were all processed in the diagnostic lab at Addenbrooke's, but sequenced either in Ian's lab or at the Sanger. And the care home residents were identified either by using address search terms in our hospital information system and by using the Care Quality Commission registration information. And this was actually a really, really difficult thing to do, to absolutely identify all the care homes, because they had, you know, slight differences in their addresses, or, you know, some of them had sort of nice names like Meadow House that didn't necessarily identify them as a care home. And then we decided to do analysis looking at viral clusters based both on genomic differences and time differences between cases. So again, this just basically shows a phylogenetic tree of the care home genomes. It's about 700 in there altogether. And we've just highlighted the top 10 sort of biggest clusters, as it were. And what we found were two patterns, really. Some of the care homes clustered very closely together, and that was consistent with a single outbreak that spread throughout the care home, and others seemed to have evidence of multiple introductions. And this was investigated further by Jerry Tonkin-Hill, who was at the Sanger, who used the trans-cluster algorithm to basically integrate genomic similarity with time difference. Again, he looked at, in fact, all of the, I think, 200 care homes in the study. But this slide just illustrates the top 10 care homes. And again, what you can see, there are two patterns. So some seem to have a single large outbreak of infection, and others seem to have multiple smaller separate clusters. And then finally, similar to what Andrew mentioned, we noticed that there were some genomes that were quite closely related between two different care homes. They were in fact geographically quite closely related, only about 1 kilometre apart. But in fact, there were two healthcare workers that were subsequently found to be working at both care homes. So what did we conclude from this study? Well, this was a large study that investigated COVID-19 infections among, I think, about 300 care homes and 1,000 residents in the east of England. We looked at some of the epi data and showed that they had a significant burden of COVID-19 infections, and about 43% of the patients admitted to hospital died. And we used a clustering algorithm and demonstrated how genomic and epi data can be integrated to define possible transmission networks. And we identified two different patterns of transmission that might require different infection control approaches. Okay, and then finally, I'd just like to mention our favourite tool that was developed locally in Cambridge but hasn't so far been mentioned. So this is the A to B COVID tool, which was in fact developed by Chris Illingworth at the MRC Biostatistics Unit. And he basically uses a novel network reconstruction algorithm to infer patterns of viral transmission in patients and hospitals, patients and healthcare workers in Addenbrooke's in the first wave. And he combined a whole load of different data. So date of symptom onset, location of patients and location of healthcare workers, i.e. which wards they had worked on, and viral genome sequence data. And basically showed an uneven pattern of transmission between the individuals, with patients being much more likely to be infected by other patients than by healthcare workers. And he also found evidence of super spreaders. So 21% of individuals seem to cause 80% of the transmission events. And that paper has also been published in eLife. And in fact, the A to B COVID methods paper is only available as a preprint, but has been submitted elsewhere yesterday. So in terms of final reflections on the Cambridge COG-UK experience, I think we were very fortunate to have a talented, motivated group of individuals with complementary skills who came together sort of voluntarily to work together on this. And as I said, many of them were PhD students or postdocs or lab technicians who volunteered to come in and work during incredibly challenging times. And we were fortunately able to generate and analyze the sequence data very rapidly and use this to support hospital and community outbreak investigations. And we developed a new analysis tool which has been used locally in the first and the second waves of the pandemic and is undergoing refinement, in fact, in collaboration with some of our UCL colleagues. I can't begin to outline the number of challenges that we faced, but they're common to the ones that have been described earlier during the course of the day. But in terms of our particular challenges, we had changes in testing strategies, changes in diagnostic platforms, and changes in personnel over the time period. And this made it pretty challenging to sort of maintain the level of service that we had hoped all the way through the last 18 months. But like everybody else, I think we found it to be one of the most difficult and yet one of the most rewarding periods of our lives. And it brought together, as I said, a lot of us had never worked together before the pandemic. And in fact, when we had a couple of people left the group and we ended up going out to the pub for dinner for a socially distanced meal in the garden. And some of us, in fact, had never met face to face. So some of the people doing the analysis had never met some of the people in the hospital before that dinner. So this was just something that I think Andrew Rambo, generated the original image and Ian tweeted it. But this is the sort of early members of the COG-UK team. And I'd really like to thank them and in fact, everybody else who appears on this slide, including members of the broader COG-UK consortium, and without whom we would not have been able to do this work. So thank you very much.
Thank you very much, Estee. That was great. Our next speaker to represent Cambridge is Dinesh, who's going to give us something more of a personal experience of the last 18 months or so. Please take it away.
Hi, so I'm Dinesh. I'm a clinical PhD student at the University of Cambridge, for those of you who don't know me. I won't be giving much of a science-based talk, because I think I've spoken at many analysis meetings and showcases about some of the work that we've been doing, but more about the experience I've had as a PhD student entering at the point of the pandemic, and also the support I've had from COG-UK. So I entered COG-UK slightly late, around August 2020, and prior to this, I was on the wards at the Royal Free. In the middle, you can see me. It's a slightly dramatic photo, probably too dramatic for what we were seeing on the wards, but it probably isn't a stretch to say that the wards at the time were quite busy. And what got us through was an incredible amount of team working and people coming together with the sole focus of patient care, more than what I'd seen before in the 7 years prior that I'd worked on the wards. And the kind of so that the particular experience, I think it would be completely appropriate saying it was completely mirrored in what I saw when I was working in COG-UK, and the efforts that I saw by individuals and teams in COG-UK were at a minimum on par with what I saw on the wards during those 6 months. And this was at the Royal Free, where we had over 2,000 patients over 2 months in the first wave. So it's very proud. I'm very proud to be part of this particular group. Now, in terms of why I also found it very daunting, starting my PhD with COG-UK and being asked to do some quite kind of significant analyses, was I had no formal research experience, and particularly zero experience in bioinformatics and computational biology. No experience of genomics and bacterial or viral. And my initial PhD title was Understanding the Biological Basis of Staph aureus carriage, which is very different to what I went on to do. And then outside of the BCOG group, I had no kind of collaborative links. So it was quite daunting. But we did go on to achieve a lot despite this. And before I go on to mention how we did this, I'd just like to highlight what we did achieve as part of the group. So working with the COG management group early on, I was able to work to extend COG's links internationally with the Foreign Commonwealth Office. I was able to host multiple analysis meetings, which actually were a great learning tool for me to see how some amazing academics were doing some kind of cutting edge or implementing some cutting edge methodology. I was able to evaluate transmission within care homes, which led to a couple of publications. And I had the privilege of presenting to SAGE and also SAGE subgroups on the efficacy of travel restrictions for limiting SARS-CoV-2 transmission, and also transmission within higher education settings, which went in as reports to not only SAGE, but also SAGE subgroups and the SPIM groups, which are now under peer review for publication. So obviously, oh yeah, sorry, and actually, we also found ourselves in the media, which was kind of very, apart from that Guardian picture, kind of a completely new experience. And probably the most important was how one of the pieces was used to analyse whether it was a good decision for Prince Charles and Camilla to travel to Greece, which actually has very few links to the actual research we did. So how do we go on to achieve this? Before I go on to talk about COG, I would like to mention Sharon and you and my supervisors, who at times were kind of on the phone to me daily to provide me with the resources to carry out some of the to answer some of the important questions we were seeking to answer. And I had a kind of prepared list of things which COG-UK kind of brought to the table, which allowed me to kind of flourish in my PhD or in my first year of my PhD. But actually, it's not better said than all the talks that we've had up until now. There was a huge amount of work from many faces who I've never seen before, and not even on a Zoom call. So from logistics to sequencing, all of which would generate data, which I would go on to use in some of the analyses that I would conduct. And then actually, one thing I could say is COG-UK did foster like an amazing collaborative ethos. And these are just some of the institutions, obviously within the University of Cambridge, but also unexpectedly for me outside of the University of Cambridge, I had multiple academics who kind of to me were famous faces because they were producing some amazing pieces of work, who would take the time out and at times days out to teach me how they were conducting their particular analyses so I could replicate them on some of the questions I wish to answer, for which I'm incredibly grateful. And then finally, I'd just like to say that I did pass my first year PhD Viva a couple of weeks back. So the title slightly changed, but it's been an incredibly successful process for me, for which I'm incredibly privileged to be standing here and giving a talk about. But it did include 2.5 pages of acknowledgements. And they weren't just individual names, I actually condensed them down into groups of people. And then thank you for listening, but also thank you to everyone here and across COG-UK for all the work that they've put in, not only supporting my individual PhD. So yeah, I'm very privileged, but no, just supporting the pandemic response. It's something that I see as quite like a stark contrast. There's a lot of celebration of the NHS and the work that goes on in the wards. However, kind of seeing both sides of it, I feel equally proud being on either side. So I hope that comes across in what I've said today.
Thank you, Dinesh. I'm not crying. So our final speaker for Cambridge is Katerina Galai, who's going to talk a little bit about the management team and organizations.
Different things. We're management team, we're admin team, we're project team, we're all sorts of teams. But I think what I wanted really to reflect a little bit on today is everybody talked about, how it started, everyone's journey, and I think it's been really interesting to see different perspectives and different views of everyone's journey. So I think I'm not going to go into too much detail about how it started. We all know that, there was an existing expertise, an existing infrastructure, which was leveraged. And then there was 11th of March and everybody came together. So the point at which I joined was around August. So by then, most of it was pretty much in place. We had the governance structures, we were accountable, we had we had all of the mechanisms to keep us in check. The management team was set up and running, the operations was scaled up, and going back to the earlier talks of the day of what Christina and Catherine were talking about, the data processes were set in motion, the consortium agreement was underway. So, and then it was basically a very interesting time because August also felt like a bit of a downtime. As far as I understand from the pace before, we canceled the steering group meetings, and so I started, and for the first 2 weeks, I equally to what Dinesh was saying, I had daily calls with Sharon, and I think after 2 weeks, I said to her, well, what can I do? What can I put in place? And I think in so many words, I basically say, do what you can. And so afterwards, after kind of a short period of time, we ended up with a slightly different structure. And I'm not saying it's certainly not all me, but I think it's the kind of the empowerment and the ability to run with it. So what we kind of evolved into is this cross-functional program that worked very effectively. That was, I think managed as best as it could and as transparently, given all of the difficulties and given, the fact that we're working across so many different cultures and so many different organizations. But if we're talking about sort of the management and planning team or the admin team or the project team, for such a massive consortium, it's a very, very lean team. It's a very small team with made up mainly of non-scientists who are so dedicated and so in awe of everything that the consortium is doing, that I think it just requires that extra shout out, because people are not doing this for publications, they're not doing this for praise, they're doing this just to keep everyone else moving and going. And I think that's been the case over Christmas. Oh, so yes, so then a lot of people don't know is actually that the transition, the kind of the PHE strand came in around December time. So when it was announced that we got extra funding, I think not everyone understood, and including myself, that came from Testing Innovation Fund, which meant that it was a government-to-government award, which meant that it couldn't just be administered through COG. So a bunch of us took on PHE contracts and developed teams on PHE side just to be able to set up agreements and pay people and increase, scale up the kind of the efforts. And Neil over here was sending those contracts that we put together on Christmas Eve as well. Christmas Eve was big this year. So well, last year rather, hopefully it's going to be a different time. But and I think, I'm not sure why I put it in red. Maybe it's kind of a bloodbath experience, reminiscent. But then it's gone away now, so it's fine. But I think making sure that I'm already over time. So I'm just going to very quickly just reflect on why it's important to have a certain structure in place. Why couldn't we sort of just carry on as a group with sort of fairly flexible structures, so what did we do? How did we do it? I think it's fair to say that our group supports, you know, a fully it's not a fully virtual consortium, obviously, as we would have seen from all of the images of people in the labs, but our group has been a fully virtual group, and supporting about over 500 members has been interesting, and it's been very paced and very much at scale, given the number of weekly, daily Zoom calls, minutes, agendas. It's been fairly elaborate. It allowed us to work across organizations effectively, to be sort of to come to those hated board meetings, but to be taken seriously and to actually put COG's, you know, advocate for COG's interests and advocate for all of the partner institution interests to the best of our ability. We managed to coordinate publications and get sort of a semi effective process going, facilitating access to data. Also, all of the public engagement that the people were talking about, we've shout out to Georgie and to Elaine for managing all of the media inquiries and for setting up, revamping the COG website and, you know, doing so much work just to make sure that the consortium keeps as informed as it possibly can be, given the numbers and given the scale of activity. People got paid. That's no small task. Everybody got paid, hopefully on time. But again, coming from various funding streams, it was a massive challenge to make sure that everything gets set up, streamlined, and issued properly. And I think finally, and what I sort of take most pride in, is that I feel like this is a team driven by service. This is a team that hopefully enabled the science to be at the forefront of everything. So you guys don't need to do it. So we were doing it. And I know obviously there's been a lot of administrative burden on every individual team, and the research officers have been amazing, and it's been tiresome, but hopefully the work that we've done has taken a little bit off everyone's plate and allowed everyone to focus on the task at hand. That's that. While I'm here, I'm just going to introduce Angela Beckett from Portsmouth. Please come up and join us.
Okay, hello. So thank you, everybody. I'm going to keep it short and sweet because I know we're getting kind of towards the end of the afternoon. And Sam already spoke really well about the logistics this morning, and Kate gave like a fantastic talk last week looking at the data in depth. So today, really, all I want to do is give a little overview of our data and also just speak a little bit about the team. So who are we in Portsmouth and what have we been doing? So before the pandemic hit and anyone even heard of COVID, we were mainly working for the Centre for Enzyme Innovation at the University of Portsmouth. You might have seen something about it recently on the BBC Earthshot documentary, but essentially plastic had become so ubiquitous in the environment that some bacteria have evolved to break it down, and they kind of want to utilise that technology to revolutionise plastic recycling. We'd also been doing a whole host of other sequencing, looking at biofilms. Sam worked on a really cool project where they sequenced skeletons from the Mary Rose. They looked at muscular dystrophy work. So we kind of had like an overview of like lots of different types of sequencing projects. And then COVID came along. So for me personally, my first day of my new job at the University of Portsmouth was the first day of the lockdown. And Sam said to me, "Oh, how do you feel about maybe going to the local hospital? We can sequence a few hundred samples, and in a month when the unit's back up and running, we'll just get back to the plastics project." Well, I think we all know how that went. 18 months and almost 20,000 samples later, here we are. And from then, we've really grown from a very small team of people with a MinION to something that's just grown and grown over time. And as Sam said earlier, we've sequenced samples from the whole of the South Coast, Gibraltar, the Falklands, and we also participated in the Hokie study. So what's unique about Portsmouth? Where do we get our data from? Where are all our samples coming from? So we had two main sample streams. First of all, the university integrated student and staff screening testing. And also where we were working at NHS Trust, we also had access to the swabs from the staff and patients. So thanks to the amazing people working at those testing centres, 30,000 lateral flow tests were performed. And of those, anything that was positive obviously went forward to PCR. And using this, we were able to have a real look at what was happening amongst our student population at the university. So as you can imagine, Freshers Week, all that partying, going out 7 days a week, you would see a spike in the number of cases compared to the rest of the community. And you can see that because the bold blue line is the Portsmouth community samples. However, compared to other people of their age group in the community, they weren't faring too badly. Another thing that was quite interesting was that in December, as those numbers of community cases increased, in line with the prevalence of B1.1.7, the university cases stayed relatively low. So we're thinking to ourselves, you know, what could be happening here? And what we kind of came up with is that we think that a lot of the students would have gone home at Christmas and probably stayed there, so they weren't then bringing that back into Portsmouth. Moving on now to the hospital. So they started their vaccination programme in December 2020, and by the end of April, 80% of people had been vaccinated. Now, what do we expect to happen in the number of COVID positive cases once a vaccination programme has been rolled out? As I'm sure you can all guess, the numbers significantly dropped. So we were looking at 10% pre-vaccination and then 0% after the second dose. And that was just one case out of 5,500. Something to keep in mind is we are looking just between December and April here. So if we were to continue monitoring that, we might see that number increase. We were also able to look at transmission within the hospital, looking at the clusters, how it was spreading from staff and patients, patients and staff, people coming into the emergency room, so that we were really able to use that information to inform the infection control measures within the hospital. And we're also looking into patient outcomes. So now looking at the more human side of the process, and that's what we've overcome. And I'm sure you can all relate, there have been a lot of challenges, from like really long hours manually pipetting thousands of samples to getting through enough flow cells that you could feasibly make snow angels. Then there were the challenges of working from home. So if you cast your minds back to March 2020, the sun was shining and I think everyone was really glad to have a bit of a break from the office. But it didn't last long and we've been knee deep in data ever since. For the parents out there, again, like the challenges of homeschooling when you're trying to do all this other work, everyone started so ambitious and optimistic with their schedules and their planned activities. But in a pandemic, we need all the help we can get and you're never too young to start sequencing. And now really just to look at the team, because I might be the one speaking here today, but it has really been such a team effort and the people I work with are fantastic. We have Hannah, Chris, Kate and Sam here today, and they're all just incredible people to work with. They've really shown some grit and resilience through the time that we've had. Everyone's worked really hard, well, at least most of the time. So is this the end of the pandemic? I think we all know that we're going to be living with SARS-CoV-2 for a long time to come, but hopefully we're over the worst of it now. And I really look forward to the continuation of the COG-UK. And so really just to thank all the other incredible sites that we've worked with. It's been such a privilege to work with everybody and the goodwill that's gone into it has been amazing. So thank you, and thank you to you all. It's so lovely to see you all in person, and I look forward to speaking to you all later on today. So thank you.
Angela, thank you very much. That was excellent. So just a couple more minutes, bear with us before we get into the coffee break. The last item on the list is hopefully going to raise your spirits even further as we go into the rest of the day. So here's Mireille.
Hi everyone, I'm happy to present the COG-UK Superheroes section, intended as a bit of fun because you've all worked extremely hard during the pandemic. Firstly, before we dive into the slides, let's look at what a superhero actually is. A fictional character having extraordinary or superhuman powers, such as super speed, super strength, healing, etc. However, the room is full here today of actual real-life superheroes who have used their powers to contribute greatly and significantly during the pandemic. Here we have, well, we did have a short history, but you all know the history. So anyway, moving on to the leadership team. The leadership team put a call out to you all to send in your superhero poses, and we received a couple of photos. So, well, the next question is, would you like to see them? But you didn't get time to answer. So this is a massive call out to the University of Portsmouth. Thank you so much for sending in your photos, Sam Robson and team. Absolutely brilliant. So yeah, not only they're brilliant, you're superheroes and clearly good sports as well. So I'm going to do a shout out. So hopefully I'll get this right, but if not, feel free to shout out and tell me who's who. So, oh, that was super quick. Okay, so anyway, back to the University of Portsmouth. So top left, left to right, we have Angie Beckett. We have Joe Herbert, Hannah Paul, Katia Celeste and Hannah Dent. Top middle, we have Sam Robson. I would like just to mention that his daughter took this photo, so age 8. So I'm very impressed with that. Then we have Chris Byrne on the right. Kate Cook, bottom left, and Angie Beckett on the right. So hopefully I got that all right. Thank you. Excellent. Okay, so now moving on to the COG Central team. So comms and admin team representatives. We have Elaine Westwick and her sidekick Ellie here. We've got Sarah Judges, who's out the back. We've got Andy as Hulk here, and myself showing our impressive poses. So on behalf of the entire team, we really want to thank COG-UK. So big thank you. We've quickly moved on. So impressive photos from Katerina Galai and from Sharon Peacock, and I'm sure you'll all agree they're superheroes. So, a moment, just honestly, we can go back to that one. And yeah, our superheroes, Catherine Ludden and Ewan Harrison here. So again, brilliant photos. So thank you. So we'll move on. Okay, so this is the COG-UK Superheroes, which is actually all of you, everyone here, everyone on the lines. You know, members across the whole consortium have been genuine superheroes throughout of this. So we salute and we thank you very sincerely.
Okay, thank you, Mireille. Thank you, everyone, especially those that have spoken and volunteered their photos and supported all of the work that we've seen today. It's a real great effort from the East of England, South East.